This is Manos Brilakis from Dallas VA Medical Center and University of Texas Southwestern Medical School. And today we'll have the 15th webcast on complex coronary interventions. It was supposed to be given by Dr. Dimitri Karbaliotis, but he did have an emergency, so actually the webcast will be presented by myself. Before we get started, we'd like to thank the sponsors of the webcast, which is the Dallas VA Research Corporation, as well as Terumo and Abbott Vascular. What I thought to do today, different than usual, is before we go into some cases, we'd like to take a few minutes and go over some of the findings presented at TCT, which was held last week in San Francisco, and show some of the CTO-related studies and the results. The first one was the EXPLORE trial, which was presented by Dr. Jose Enriquez from the Academic Medical Center of the Amsterdam in the Netherlands, which is an extremely important study because essentially this is the first trial that compares CTO PCI with medical therapy. It included patients who had an ST elevation myocardial infarction, which were found to have a non-infarct-related CTO. It was done in multiple sites and took 7 to 8 years to be completed. And those patients who had the non-infarct CTO were randomized to either undergo CTO PCI within 7 days from the time of presentation with STEMI or to medical therapy alone. The primary endpoint was left ventricular ejection fraction and left ventricular end-diastolic volume as assessed by magnetic resonance imaging that was performed 4 months after the procedure. And these were the results at 4 months. The ejection fraction was essentially the same between the patients who were in the CTO PCI arm or the placebo arm. It was 44.1 versus 44.8, no significant difference. And similar findings were seen in left ventricular and diastolic volume, which was 215 and 212 in the two groups, again, not statistically significant. One interesting subgroup analysis was that comparing patients with LAD versus non-LAD CTO, and what they found is that those who had LA CTO, they actually had a benefit with an improvement of 6.8 points in left ventricular ejection fraction, where those who had a non-LAD CTO had actually a decline of 3.2 in LV ejection fraction. It's a non-primary secondary analysis. It's hypothesis generating, but creates some questions about the whole study. The incidence of endpoints was similar in the two groups. There were 4 cardiac deaths in the CTO PCI versus 0 in the non-CTO PCI, and marginal significant difference. Everything else, incidence of MI, incidence of MACE, were similar in the two groups. So the study essentially was a negative trial, and there were main limitations, namely the long inclusion period. The success was 72% as reported by the core lab, so lower success than the 90+% achieved in contemporary series. I'll show you in a subsequent presentation. And it's short-term follow-up and not powered for clinical endpoints. But it did appear that CTO PCI is feasible and safe, but the benefit was questionable. One of the things that was questionable was the success rate. So it was 80% self-reported and 72% as adjudicated by the angiographic core laboratory. And of course, the analysis that begs to be done is what would the results be if only the patients who had successful CTO PCI were included in the actual results. Another large study that was presented for the first time at TCT was the Open CTO study run by Aaron Grantham from Mid-America Heart Institute. And that was a 1,000-patient study from 12 sites that was performed to evaluate the outcomes of hybrid CTO PCI in terms of success, safety, efficiency, health status outcomes, and costs. and essentially 1,000 patients were enrolled at 12 clinical sites, and these are the sites all across the United States, and these are very experienced centers and very experienced operators. So this study does represent kind of the best of contemporary CTO PCI in the United States. It has multiple stents, which is the auditing through NCDR. So if someone was not including all their CTO cases in the registry, that could be found. It also had an angiographic core lab to perform analysis of all the films, centralized follow-up, adjudication of all events, and included several operators as shown before at several sites. That was the enrollment. That was accelerated by inclusion of multiple sites, and this is the enrollment as a percentage of the total by every site. Patients were typical of what we see today in CTO PCI. Most of them were men. Mean BMI was about 31. About 41% had diabetes, and 36.9% had a previous coronary bypass graft surgery. 51.1%, and complete revascularization was achieved in 82% of the patients. Most CTOs, as expected, were in the right coronary artery, about 60%, followed by the LAD and the circumflex. And the mean occlusion length was 29.9 millimeters, with a JCTO score 3 or more in 19.7% of the patients. So how about appropriateness, which is always a question with CTO PCI, but essentially there was a very, very small group of patients, 1% or so, that were mapped in the rarely appropriate category, with the vast majority being marked as appropriate or maybe appropriate, and some of them as unmappable. And as anticipated, the number one indication for being referred for CTO PCI was to improve symptoms. One of the characteristics of the hybrid approach is its flexibility, which means if one strategy does not work, then one tries to find another one that might be more successful. And this is illustrated in this particular diagram showing the first strategy and the second strategy. The first strategy was undergrade wire escalation in 55%. It was undergrade dissection reentry in 14%, and retrograde in the rest 31% of the patients. And if this didn't work, the second strategy was either undergrade dissection reentry in 44%, retrograde dissection reentry or wire escalation in 45%, and undergrade wire escalation in 12%. By doing this change of strategies, a success rate of 89% was achieved. Mean procedure time was 119 minutes. The mean radiation dose of the patient was 2.5 gray, and the mean contrast volume was 265 mL. So excellent success and fairly efficient procedures with relatively short procedure times and relatively low radiation and contrast dose. A very important finding was the significant improvement in health status after CTO PCI. There was a significant increase in patients reported angina in all components of the Seattle Angina Questionnaire between baseline and 1 month. So the patients did feel significantly better. There is no control, as this was a single-arm study, but the magnitude of the benefit appears to be substantial. The same was found in terms of dyspnea, that in the Rose dyspnea score that was significantly reduced from baseline to 1 month. And the same was found for depression, with a significant improvement between baseline and 1 month. By the way, there was another study, I don't have slides, from Dr. Farouk Schaffer from Mass General, that demonstrated a significant improvement in quality of life, mainly amongst those patients who had depression to start with, and those were fairly common among CTO patients. About 40% had significant depression before the procedure, and that significantly improved after the procedure was performed. In terms of complications, the in-hospital mortality was 0.9% and 30-day 1.3%. Emergency surgery, 0.6%. There was radiation injury in 0.1%, and unplanned revascularization in 2.6%, and rehospitalization in 14.7%. So obviously, there are some recurrent events. The patients may need to come back to the hospital or undergo repeat revascularization procedure, but overall outcomes appear to be pretty robust. So the Open CTO registry did demonstrate high success, high technical success with good efficiency and improvement, significant improvement in the patient quality of life. There remain some questions regarding the risk of complications and what we can do to further reduce that risk. But overall, it does confirm what we all believe, that CTO PCI does provide significant clinical benefit to the patients. Similar results were presented by James Pratt from the United Kingdom in the hybrid UK registry, which included several sites in the UK, with a variety of JCTO scores. Many of them had pretty high JCTO score. There was 30% with JCTO 4 or 5, and another 24% with a JCTO score of 3. So these are not cheap shots. These are fairly complex, fairly challenging CTO procedures. And the patient did have a significant improvement with angina class Canadian Society 0 or 1 in 88% of patients during a mean follow-up of nearly 1 year. And outcomes were favorable with death 2.5%, MI 3%, and TLR of 4.5%, which is excellent. The final strategy was undergrade wire escalation, mainly for the simpler CTOs, but as the lesions became increasingly complex, then there was an increase in undergrade dissection reentry use, as well as an increased use in retrograde wire escalation and retrograde dissection and reentry. Another study from the Progress CTO registry revealed contemporary patterns of guide wire and microcatheter utilization in CTO PCI. The outcomes of Progress are very similar to those of Open and the UK hybrid registry, with success above 90%, low complication rates, and use of various techniques. All three techniques are required for successfully recanalizing the CTO. And there's a significant proportion that require change between techniques to achieve the final high success. This was an analysis from some of the Progress CTO sites showing that the currently most commonly used guide wire for undergrade wire escalation in the US was the Pilot 200, which was the most commonly used and actually the most likely to achieve successful crossing, followed by the Filter XT guide wire, and followed by the Confianza Pro 12. One limitation of this particular analysis is that many of the years during which these procedures were recorded were before the introduction of the Gaia wire, which seems to offer some advantages, and we hope to see more information of that in the future. But overall, does demonstrate a little difference between Japan and Europe, in which the stiffer wires are less commonly used compared to the Pilot 200, which is not very commonly used outside the US, but it's a very commonly used guide wire in the United States. Regarding microcatheter, the most commonly used was the Corsair, followed by the fine cross catheter or an over-the-wire balloon. And a small update regarding new devices. Professor Leszek Bryniarski from Poland, from the Jagiellonian University Medical College, presented the first in men study with a novel CTO crossing device called the NovaCross. That device is a microcatheter that has a nitinol helical scaffold that, once deployed, can provide support against the vessel wall and support the guide wire from crossing attempts. And there were several cases that were performed. This is the characteristics of the microcatheter, which accepts any standard 0.0114 guide wire. Actually, we are very honored. We're going to have Dr. Briniarski present the next complex cardiovascular interventions webcast in early November. So I will not go into detail. I'll have him present the preliminary data in our next webcast. And moving on to a case presentation. That was one of the cases that we recently had in our lab. This is a patient who has a right coronary artery chronic total occlusion. There are multiple collaterals, both ipsilateral as well as contralateral from the left. There is also a previously deployed stent in the distal right coronary artery that is always a problem because it can create challenges, as we will show later, on subintimal crossing. The patient also had some proximal LAD disease and had several septal collaterals with retrograde filling of the posterior descending artery. We first placed a stent in the proximal LAD. Because of the stent in the RCA, we wanted to go with a primary retrograde approach, especially given the proximal camp ambiguity that was present in this patient. So the proximal LAD was stented, and then we did a significant effort trying to cross from the LAD into the PDA, surfing several of those septal collaterals, however, without success. And as has been shown in other studies, about 1 in 5 of those septal collaterals may not be crossable with guide wires, even in highly experienced centers. So we decided to switch to an undergrade approach. This is an ambulance guide, which was deep-seated. And the first question was, how can we understand where the CTO starts so we can start with our guide wires? And one view for the right coronary artery that can be extremely useful is the lateral view, which is shown here. There is still some ambiguity in terms of the origin of the occlusion. We do see the proximal RCA. We see a large acute marginal branch. We also see a large atrial branch going backwards. And then there's another little branch connecting to another acute marginal branch and reconstitution in the middle part of the RCA with 2 more acute marginal branches. And the question here is, where exactly is the proximal cap? Is the proximal cap over here? Is the proximal cap over here? And IVUS can be helpful in some cases like this, but in this particular case, there was actually no good side branch close to the possible area of occlusion to let us identify the proximal cap. So we played the film several times. We looked at it again and again, but we were unable to determine exactly where the proximal cap was. And also the guide was deep-seated, forcing us to switch to a little shorter guide that was an AL 0.71, which did seem to fit a little better, but then didn't provide enough support. And then in cases like this, where the proximal cap remains ambiguous, one way to resolve the ambiguity is to try to create a dissection intentionally. And this technique is called move the cap or scratch and go. Aaron Grantham has been instrumental in developing it. And what the goal here is to create a dissection and then being able to advance a knuckle wire past that part of the vessel we know is clearly where the vessel architecture is, through that area of ambiguity, because subintimal space with a knuckle is much, much safer to cross than trying to advance a guide wire through a tortuous or unknown part of the vessel. So that's what we did in this particular case, and we were able to create this dissection, in part because of deep intubation of the guide, which had to be changed to a JR4. And because the JR4 did not provide good support, we did insert a small 1.5 by 8 millimeter balloon into the side branch, and by doing that, we were able to get good enough support to be able to advance a microcatheter, a Corsair in this particular case, and then a polymer jacketed guide wire, and start essentially advancing the knuckle through that area of ambiguity. Again, that's called the scratch and go, create a dissection, and then advance the knuckle through. Another way to do this would be to inflate a slightly oversized balloon in this proximal part of the vessel to kind of intentionally create the dissection. But in any case, there is the saying, trust the knuckle. Once you're in the subintimal space, then the knuckle is a much safer way to advance, especially through unknown territory, than advancing a stiff guide wire. So everything went well from that point until the knuckle reached all the way down to the previously deployed stent. And we knew that this was going to be an issue because the deployed stents can essentially hinder the undergrade movement of the guide wire knuckle. And that's exactly what happened in this case. The Corsair is all the way down. We have a fairly large knuckle, but we weren't able to penetrate through that previously deployed stent. We tried a Pilot 200 guide wire. We tried a Filter XT guide wire. You see the guide wire at some point exited from the vessel structure, but this was not working. So the way we used to get through the difficulty was by inserting a cross-boss catheter and trying to advance the cross-boss with a fast spin technique, hoping that with the extra support it gets, it might be able to let us go through that occluded part of the vessel. Unfortunately, the cross-boss was also stuck in that proximal part of the stent, possibly because it was meeting resistance at an area of previously deployed stent. So cross-boss would not go. So what the next step was is to pull it a little back and then insert a new Pilot 200 guide wire and use the cross-boss to essentially provide extra stiffness and support to the wire. And sure enough, as you can see here, we were able to advance the cross-boss around the stent a little bit. So we're continuing our subintimal dissection, essentially going around the stent. And this might be a little anxiety-provoking for many operators because now we have an old stent and we're going definitely around the stent, but it has been done. It has been done in several studies. There's actually a case report in CCI from Tulane, published this year, showing that this is doable, and even after stenting and crushing essentially the old stent, the patency can be good later on during angiographic follow-up. So the goal is to continue to go around that stent and then go to the posterior descending artery and re-enter. And again, slowly by advancing a knuckle through the cross-boss catheter. It was invaluable having this anchor balloon into the acute marginal branch. We were slowly but steadily being able to get around the stent, and finally the knuckle advanced past the previously stented segment, going into a side branch. We had a very hard time redirecting the knuckle, but this is where the Gaia wires can be very useful. For members of the audience who are not familiar with the Gaia is a new category of wires called composite core wires. And what they have is essentially a dual core, which allows excellent transmission of torque from the back end of the wire to the front end of the guide wire. By doing that, the wire could advance around that area of tortuosity and being able to redirect us into the posterior descending artery. And here we're now with the wire dancing around the posterior descending artery. So now we're next to the re-entry zone, And the question is how to achieve reentry in a fairly small and diffusely diseased posterior descending artery. Of course, it's important to have the retrograde imaging so we can see where we are, and also we don't want to inject anymore during in the undergrade direction because that can propagate a dissection and make things worse. So before we do anything, we disconnect the manifold connecting to the undergrade guide catheter. We tried to advance a Stingray balloon, but we were unable to. There was a lot of resistance distal to the stent. And for such cases, we found lately that use of a threader, which is a combined balloon and microcatheter, can be fairly effective in having axial penetration through these tough areas to go. And this is an algorithm that can be used for crossing balloon uncrossable CTOs, like this particular one. And the first simplest thing is to get a small balloon or a threader catheter. Another one that can be very useful is the so-called glider balloon that is designed to go through jailed stent struts. And another way is to rupture a balloon in the vessel, do granuloplasty, although we might be a little hesitant to do that when we're in the subintimal space, as in this particular case. If this doesn't work, then there are second, third, and fourth line techniques, essentially using microcatheters or the Turner's catheter and anchor techniques. We already had a side branch anchor in this particular case. Then if this doesn't work, then one can use more aggressive techniques like laser and rotablator if the rotowire can be advanced. And finally, fourth line approaches are to go subintimal and either crush that area that is very hard to penetrate, or essentially anchor the true lumen guide wire with a subintimal balloon to increase support and deliver equipment. Fortunately, in this particular case, we didn't have to do any of that because the threader went and we were then able to deliver our Stingray, which is in here in the proximal part of the posterior descending artery. Stingray reentry can be challenging in those small vessels, but can be facilitated by doing the so-called stick and swap technique, in which we advance a stiff wire first, use the Stingray wire, and then we switch it for a polymer jacketed, usually a pilot 200 guide wire. And this is an example of this case. So we are sticking up first. In this case, actually, we were not sure where the vessel is located. So instead of taking multiple images, what we did is stick both on the top between the two markers, as well as stick on the bottom. So creating a connection both sides, and then going down with a polymer wire, pilot 200 in this case, which is in here, go from the top, and then continue down the vessel. And this is one way of going through these lesions. Another way, if there's a hematoma, is to do the so-called straw technique, in which there's aspiration of the hematoma. And what we did is called the double-blind stick and swap technique, which we did the stick on both sides and then switched for a polymer guide wire. Another option, if the pilot guide wire does not work, is to actually use a guide wire. We had good luck in some cases. When the pilot doesn't go, we'd swap for a guide wire, which is very, very torqueable, and that can help us get back into the distal true lumen. So in this particular case, we have the pilot wire, and in this view, the wire seems to be into the true lumen. But to be 100% sure, we did a orthogonal view, which also confirms that the pilot was indeed where it's supposed to be in the distal true lumen. And then after switching for a workhorse guide wire, we did intravascular ultrasound, which provides very interesting images showing the previously placed stent and showing how we're essentially going around the previously placed stent in the so-called vessel architecture. So a fairly unique image showing our advancement around the previously deployed stent and explaining why we had so much difficulty advancing equipment through that previously stented area. We went ahead and placed several drug-eluting stents, restoring TIMI-3 undergrade flow. And this is the final intravascular ultrasound showing good stent expansion, stent apposition. And there is the crushed old stent in this semi-lunar morphology, which now is essentially next to the new stent that's placed in the distal lumen and then in the subintimal space, going all the way to the right coronary artery ostium. So I think this case provides several interesting findings. The first one is the importance of changing strategy if the initially selected approach does not work. In this case, it looked like a retrograde case, and we did try hard to go retrograde. We did do surfing on multiple septal branches. However, this did not work. But then, once it didn't work, we actually switched to undergrade, which proved to be the final successful strategy. It also shows the importance of having strategies to deal with proximal cap ambiguity. IVUS is a great one when feasible. It was not in this particular case, and that's why we did the scratch and go technique, creating intentionally dissection in the proximal part of the vessel, then advancing a knuckle subintimally through that area of dissection, and then going around that area of ambiguity with the safety and the security and knuckle wire providers. We did have a lot of difficulty going the old stent, and that's where the use of the crossbox catheter with its stiff and very supportive body proved to be extremely useful for giving us the support that was needed to go around the stent and cross into the distal subintimal space. The Gaia wires were very useful for redirecting from the PL into the PDA. Once we couldn't get through the balloon into that area, we used a threader to make a channel and deliver our Stingray balloon. And finally, we did use the double-blind stick and swab technique to be able to re-enter into the distal lumen in this very, very small and diffusely diseased right posterior descending artery. Again, another tip and trick for allowing re-entry in cases where the vessel is small and diffusely diseased and minimizing contrast use and probably saving time. So that's all we have for today. The next webcast, as mentioned before, is going to be from Professor Leszek Bryniarski from Poland. He's one of the European leaders in CTO PCI, extremely talented operator and excellent presenter. And he will be joining us very soon on November 3rd to discuss some interesting cases as well as share his experience with use of the NovaCross catheter into CTO PCI. Once again, I'd like to thank you all for being on this webcast today. We apologize for Dr. Karbaliotis. Again, we'll have him join us in a subsequent webcast, which will be rescheduled. And we'd like to thank our sponsors, Terumo and Abbott Vascular, as well as the Dallas VXS Corporation for organizing this particular event. Thank you very much.